Often, the truth is not sensational. Many times in healthcare, the truth is borne out over years of collective experience and, importantly, by high-quality scientific research. How then should we help our patients who have encountered information or facts that go against reliable evidence? Patients who now hold deep concerns about the safety of health treatments that could reliably maintain or enhance their quality of life. I'm Peter Norton, and in this special event by the Australian Society of Endodontology New South Wales, we'll be addressing one source of alternative facts. It's a documentary entitled Root Cause, which has done the rounds of entertainment streaming services worldwide. The film attributes an impressive list of human maladies to certain types of dental treatment. But to be clear, this event is absolutely not a closed-minded rebuttal. Instead, it's a chance to examine the claims made by the filmmakers in the context of high-quality evidence, a panel of renowned experts, and your comments and questions. So let's meet our panel. Dr. Mehdi Rahimi is an adjunct professor in endodontics with Charles Sturt University and is the current president of the Australian Society of Endodontology New South Wales branch. He's well known for his work in teaching around Australia and beyond. Professor Morteza Agmashay is a senior staff specialist medical oncologist at Illawarra and Shoalhaven Cancer Care Centres and is an honorary clinical professor at the University of Wollongong Graduate School of Medicine. Professor Laurie Walsh is the research group leader for advanced technologies and clinical microbiology at the University of Queensland. He holds a PhD in immunopathology and a DDSC in oral pathology. He joins us by video link from Brisbane. And due to time zone differences, Dr. Brett Gilbert from the USA will join us in several pre-recorded segments. Brett is a clinical assistant professor in the Department of Endodontics at the University of Illinois Chicago College of Dentistry. We'll be taking your comments and questions during the event, so please get involved in the discussion. If you're watching us on Facebook Live, this next information is for you. Make sure you're watching us from the Australian Society of Endodontology New South Wales Facebook page. That's important because we won't see your comments or questions if you submit them from any other Facebook page. Gentlemen, I guess we probably need to summarise the Root Cause film for any of our viewers who haven't seen it. So, in under a minute, the narrator sustains a dental injury to an upper central incisor from a violent assault. The tooth receives endodontic treatment and 10 years later, the narrator experiences a panic attack in Thailand. His symptoms deteriorate into anxiety, depression and erectile dysfunction. He tries some conventional medical treatment followed by an exhaustive list of alternative health treatments to no avail. Finally, an alternative health practitioner asks a special antenna what the problem is, and it's decided the narrator's issues are caused by an infected root canal tooth. The tooth is removed, a dental bridge is placed, and gradually the narrator feels better, including in the bedroom. The film is liberally peppered with various purported experts who attribute many systemic conditions to endodontic treatment, incorrect extraction technique, and titanium dental implants. The experts refer to study after study, but they don't seem to supply any ready references. Guys, is that a fair summary of the film?
Yes.
Agree. Look, I'm confident in saying that everyone on this panel feels tremendous sympathy for this filmmaker. He's obviously had a horrendous time in his health history, and I think we're all thrilled that he's doing better now. I even feel admiration that he fought so hard to get well and then shared his experiences with the world, even if I have questions about the film's assertions. On that note, the film makes various claims that sound reasonable. Let's look at one now.
There's no branch of medicine that exists where a dead organ is left in, except in dentistry where a root canal is left in. If a guy's got a gangrenous toe, you gotta cut the toe off because it's bacterial infested and it's toxic and it's gonna kill the patient. If you think that you can get away with an infected toxic tooth and not have a systemic consequence, I think you're deluding yourself.
Well, Laurie, let's go to you first. That assertion sounds reasonable to me, but does it stack up in reality?
Well, actually, it's just a little bit too simplistic. We know that enamel is not a structure that has vascular flow through it. We know that root-filled teeth have got a vital periodontal ligament with a very vigorous, active immune response within that periodontal ligament that we're really only now coming to understand very clearly. So it's actually not true to describe the root-filled tooth as being completely dead and somewhat noxious as a result of that.
Okay, well, let's look perhaps at the film's most central dental claim about root canal sterility.
Well, root canal procedure is still a very, very popular thing in dentistry because no one wants to lose a tooth. But more and more people are beginning to realize, even from the current day modern and very traditional literature, that it's impossible to sterilize a root canal system.
Most conventional dentists believe there's no problem with them, but I personally couldn't disagree more. I think that they're a hidden source of toxicity for almost anyone.
The reason that root canals have an inherent problem is that because we know that nowhere else in the body can we leave dead tissue. Anywhere else in the body, your appendix dies, you have dead tissue that doesn't heal in any other area of the body, we know we have to remove that because it's a haven for bacteria and it's not compatible with health. And the same is true in a tooth. A tooth is a living structure, has a blood supply, has a nerve supply. And so when a tooth dies or becomes infected and we decide to go in and do a root canal, even the best endodontist or root canal specialist can do a great job at cleaning out the main canal of any of the teeth. But what they can't get to are all of these thousands of tubules. You could see if you cut a tooth in half or under a microscope, you can see these thousands of tubules that run out in every different direction at all sorts of angles off from the main canal.
Those microtubules are big enough for a bacteria to fit in, but not much else. And the problem is if you've got 6 to 8 miles of microtubules in a single tooth, it's impossible. You can see why it's impossible to sterilize that tooth.
So, after the root canal has been performed, unfortunately, bacteria still reside within the tooth. And now you have this nice, warm, incubated tooth where the bacteria are able to flourish. And now there is no access from the patient's own immune system to the tooth because in the process of doing the root canal treatment, the blood supply and the nerve have been severed from that tooth, so now the body can't deliver its own immune defenses to help keep the infection in check.
Well, Mehdi, you're obviously a root canal specialist among other things, and as an endodontist, so this is probably a good one for you to discuss. What can you tell us? I mean, the anatomy is so complex that we'll never get it sterile, therefore we're doomed to failure.
I just wanted to start off by saying that some of the statements obviously are very misleading and dangerous, really. I know of dentists currently that are facing legal challenges as a result of performing endodontic therapy, and then obviously such claims that the patients come back and said they've developed cancer, other diseases as a result of it. So it's a really huge issue because the world of social media is not going to go away. And the second thing is, whatever we discuss tonight, I like it to be evidence-based approach. A lot of the claims made are not peer-reviewed journals or not high level of evidence or any evidence at all.
Claims made in the film.
Claims made in the film. Probably, I think Brett Gilbert mentions that none of the claims made are actually in peer-reviewed journals, or you can find the articles that they mention. But I'd go as far as saying, look, the National Institute of Health spent a lot of money, over $1.5 million, and in 2013 came up with a result that compared the human body cells in count numbers to microorganisms, a variety of organisms. There's obviously others like viruses and things that can also reside within the body as well. And the number was 10 to 1 ratio, 10 microorganisms to every 1 human living cell.
So we're in the minority.
So unfortunately, yeah, we're pretty, we're filled with bacteria. Some of the bacteria is good in the gut, for example, and they may be commensals, but the reality is we're pretty, dirty, if you want to talk about bacteria. So the root canal system really is a very confined space, and I like to address Paul Abbott's diagram, which is the next one. So the reality is that the root canal system is in a confined space. It's encased within bone and periodontal ligament. And I often say this to dentists. They might ask me, what did you do differently by retreating the tooth? And I say, I left bacteria behind. I admit to it. But it was less than the threshold to cause disease or inflammation. Okay? If we're talking bacteria within the bloodstream, for example, you'd be on your deathbed if it's in high numbers. But even a recent publication in 2019 mentions that a healthy, pristine pulp can have traces of DNA. So the reality is that we're living with bacteria, even in vital organs. After a bowel motion, for example, you would have a transient bacteremia. So there's a lot of areas of the body that you can have transient bacteremia. I have no idea what happens to people with hemorrhoids and fissures. I'm sure they'll have transient bacteremia, but the body can cope with it, a healthy body. So it's all about how healthy is the body can cope with a low-level bacteria. We clean out the root canal system the best we can. Below a threshold that causes disease, then we seal the root canal. We entomb that bacteria like the Egyptians, entombment. And that bacteria is no longer viable. It's not going to replicate or cause problems to the body. And in case it does, even at low levels, we'll be able to pick that up. We'll be able to detect it via either signs and symptoms or via radiography. So my simple answer is we live with bacteria. So we're never going to be sterile. No part of our body will be sterile. And there are parts of the body, the hair, as an example, they exfoliate. So if the tooth was really truly dead, it would exfoliate, or the body will find ways to get rid of that. So that doesn't happen, obviously, also because of the same reason that it's still a vital organ.
All right, well, one of the next claims in the movie focuses on oral systemic links. So let's line that video up.
70 to 90% of all medical problems actually originate in the mouth. Conventional dentistry still has a focus on the mechanistic Newtonian mentality that the teeth are not connected to the rest of the body. I mean, embryologically, the teeth develop from the same tissues that gives rise to your sympathetic and the parasympathetic nervous system. The blood supply and the mouth literally will take any toxins via the lymphatic system and take it down to the thyroid, the thymus, the heart, and the rest of the body. So there is a direct connection.
Laurie, let's hand that to you. I mean, obviously you're an expert in both oral and systemic systems. So how would you assess that claim?
Well, I think I'd probably begin with the medical illustration that was put on that particular little video clip, because that's actually not the way that lymphatic flow works in the body. The lymph doesn't flow from the mouth down to the thymus to the heart. In fact, most people who are adults actually don't have a functioning thymus. It's normally involuted in the late teenage years and its function's replaced by the skin. Anatomically, lymph flows in two quite distinct chains, and it's actually part of the normal immune system as part of its immune surveillance. Even in the most medically compromised patients with very, very poor immune systems, fewer than 1/3 of their infections originate from the mouth. And 22 years ago, we published a sequence of case studies which were looking at the most immune compromised patients, which I was managing at the time, showing that in those patients, in that very unusual situation of having reduced homeostasis in the immune system, it's only in that situation where those sorts of numbers were even popping up. And as Mehdi has said, in normal patients, we actually clear bacteria from the blood system very, very quickly, within a matter of minutes, through reticuloendothelial cells, macrophages that are bound into the liver, the spleen, and in fact, throughout the circulatory system.
Well, Maury, you're our token medical person on the panel, so thanks for being with us. What are your thoughts on the comment that 70 to 90% of health problems originate in the mouth?
I guess one thing that potentially can help us to better clarify that is the history. So in regards to malignancy, which is part of my field, the history of breast cancer back to 2500 BC, which I don't believe root canal was part of the treatment at that point. And a lot of the diseases that has been established, it has been actually predated to the history of the root canal treatment. And despite that, they may try to indicate that the root canal may increase the risk of these diseases. I think any of those claim there has no sort of scientific value unless they can prove it on some published data, in the, at least some sort of case control studies. As we said, bringing some ideas or speculating some ideas, it's interesting, but there's no scientific value unless you can prove it scientifically.
All right, well, Mara, let's stick with you. This next claim from the movie sounds pretty worrying, and we'd love to hear your thoughts.
Many people have trouble getting their mind around the fact that their teeth are making them sick. But let me just tell you that a year or so ago, We looked at the last 60 cancer patients that we had seen, and 96% of them had an infected tooth in the same power supply circuit as their primary cancer, 96%.
So I'm worried. What can you tell us?
Well, there's a couple of interesting comments on that video clip. Firstly, this is, I think, a really strong claim. Is stating that 96% of all cancer comments to this specific clinic over the year or so, they actually had root canal or they had some sort of toxic tooth. And they also said they was in the same circuit power. And I understand that Dr. Tennant has a special interest in circuit power, which is not my field of expertise. But besides that, which is, I have to say, there is no, again, evidence in correlating root canal circuit power and the malignancy. But in addition, I think this is pretty much stating that the majority of the cancer is induced by some sort of tooth infection, root canal treatment. If you look up the PubMed and all the appropriate sort of databases, there's no such a correlation has been identified. In fact, I might just quickly go back to say the first time that Mehdi asked me to contribute to this, because I do have a root canal, which I had 10 years ago. And a minute after I spoke to Mehdi, I was really anxious because I never heard of it about this sort of connections. And I had a look, I did all the literature search. I went back to Google and I found that, truly there is no evidence for this. And the fact is, there is a lot of evidence to actually disprove this claim. There is at least a few literatures that I have contributed to that is actually indicate that they have done proper studies. One of them, for example, they looked at the oral health and colorectal cancers. And this is thousands and thousands of patients. There's 3 large cohorts of over 1,000 patients that they looked at clearly into the oral health, and they looked at their cancer and they see if there is any correlation between them and healthy individuals. And they also did a meta-analysis of combined studies. And the conclusion of the study was that there was no correlation between oral health and the colorectal cancers. And I will explain a bit more detail in regards to breast cancer and head and neck cancers, how these sort of claims has no sort of scientific base. Maybe in here I might just mention also that the cancer societies, if there's such a strong relation between the root canal, they wouldn't easily dismiss this. There's comments people can look up the Victoria Cancer Council. They're clearly stating that this is not scientifically true and there's no correlation between the root canal and cancer. And also similarly in the Canadian Cancer Society website, this actually clearly states that there's no correlation between these two.
Well, that's good to know, because if we take the expert's opinion in the Root Cause film, root canal is the new smoking. And from what you're saying, the evidence does not support that.
That's exactly right. And I think the danger of these claims is that it actually make public confused, because you may believe that if this is not true, maybe the smoking relation is not true. Maybe the cancer screening is not true. Maybe the high BMI in relation with the cancer is not true. And I think it does really create a cloud in the public that they may miss the true facts about the cancer risk factors as well as the preventions. And I think this is really important for us to try to educate the public properly. And I think any movies like this that has got no scientific base with such a broad sort of media release, I think it needs to be really criticized, because it can create real danger in the future in the health of the public.
All right, well, thank you for your questions. I promise we'll get to as many as we can. Laurie, the previous clip talked about power supplies and whatnot. I understand that you'll be able to help us with that, so playing the next clip now.
I remember years ago having a physician say, I can't buy into this concept of this electricity going through these meridians. I've never seen a meridian in all the cadaver labs I've ever been in. And I said, okay, when you can do an EKG on your cadaver, I'll be able to show you a meridian, because you can't find it when the person's dead. When you're looking at doing an EEG or an EMG or an EKG, we're looking at the electricity going through the body, and that is completely mainstream. Each tooth actually lies on a different meridian. So those energy pathways that we discussed, they go through particular areas. So if we're looking at the wisdom teeth, we're talking about a small intestine and a heart. As we move forward on the top and we have these molars, then we're looking at breast, we're looking at thyroid. On this side, we're looking at pancreas. On this side, we're looking at spleen. Then we move forward to the bicuspids and their lung and large intestine. We go to the eye teeth, and it's called an eye tooth for a reason, because it's connected to your eye. It's also connected to the liver and to the gallbladder. And then these four front teeth, top and bottom, are connected to the urinary tract, to the anal canal, to the adrenals, to the pituitary, to your kidney, everything that's related to that urinary tract. I use a piece of equipment that was originally called EAV, electroacupuncture according to Vol. I put electricity into the body, and then you gather data from that. So when I'm testing teeth, I actually have the person holding a bar in their hand, and that bar is the collection point, and they touch a tooth and put it in the circuitry, and then I introduce, by touching on a particular acupuncture point, I introduce the electricity into the body to see if it can go all the way through that meridian. And you start seeing where electricity is being blocked, and now you start asking questions about the person's health, and they go, wow, how did you know that? I didn't even tell you that I was having problems there. Because when the electricity can't get through, it compromises that meridian.
So Laurie, power circuits, meridians, whatever we like to call them, how do they relate to teeth, and should we be revamping how we conduct healthcare?
Well, yeah, it's an interesting little discussion, what the presenter was just saying, because in the traditional view of meridians, it's not clear from what she was discussing whether they're on the surface of the skin or actually inside the body. If you actually read the concept of meridians, they're supposed to be inside the body. But no one has ever been able to show them in a way that's reproducible. So there have been many good studies which have actually looked at so-called meridian points in healthy people. And these acupoints actually can't be found reliably by using the sorts of Vol electrical devices that have been described by the presenter in the video. In fact, the only thing that's even come close and is sometimes used is a description of a type of a vascular circuit that was identified in 1962 that's never been able to be reproduced and is in fact found distributed across the body and doesn't even follow the meridians. So there's actually no actual structure that can explain that, and those connections certainly can't be demonstrated in any reproducible scientific way. And in fact, if you even go to the journals of acupuncture today, you will find a lot of critique around some of the problems in actually trying to find good, hard, reliable evidence around this. And the World Health Organization, in a recent publication, talked about the fact that there is actually not a list of known conditions which you can actually link to particular meridians. That list is not even agreed around the world, despite what's claimed to be several thousand years of investigation into links between these purported electrical lines and different diseases in the body. So I think you'd have to say the kindest thing you could say about meridians is that they're actually imaginary.
Or at least we shouldn't be changing our ways of managing healthcare just at this stage, I suspect. Well, next up we have a worrying opinion from one of the experts about dentists themselves, and then we'll hear what Dr. Brett Gilbert has to say.
Conventional dentistry believes that you should save a tooth at all costs. And if the patient dies, well, that was the price of saving the tooth. They don't really come with the concept that you should take things that are dead out of the body.
In this clip, Dr. Ewing is implying that dentists, in which she coins conventional dentists, which I have never heard before, but she implies that we would value the tooth, saving it at all costs, over the patient's life. Imagine that insinuation, to say that we would value one single tooth over the patient living or dying. It's absolutely ridiculous. And the statistics would show that in the US alone per year, 20 million or more teeth are extracted, meaning that a dentist has assessed those teeth, determined that the prognosis is poor or hopeless, and the tooth was removed. So right there, the act of 20 million extractions would show that dentistry as a whole is able to assess the health or disease of a tooth and recommend the appropriate treatment, which is always having the patient's well-being and health at mind. The other point she tries to make is that once a tooth has been treated with a root canal, that it is dead. And this simply is untrue. When a root canal is performed, the inner tissue, the dental pulp, is removed and it's cleaned and sealed. That dental pulp tissue, its purpose, its function was to help form your tooth. Once the tooth is fully formed, this tissue doesn't have a tremendous function in the health of the tooth. Now, on the outside surface of the tooth, there are live structures. There's a cemental coating called cementum. It's created full of live cells, and these live cells attach to live ligament fibers that attach to that tooth, which anchor it into the bony socket. So the tooth, once it's had root canal treatment, does remain alive. The tissues that attach it and interact with the rest of your body are alive. They are well and they are functional. So the 2 points at which she makes here are really completely a misrepresentation of fact. They're meant as a scare tactic, and I feel it's a real danger to the public to use this information in any way as an influence into their healthcare decisions.
Well, Brett, thanks for your standing up for us as a profession. I was a little bit concerned that I was being portrayed as a dentist in a very unfavourable light. Look, in preparing for this evening, we reached out to some experts in the field of endodontics, and we've received some statements. Let's have a look at the first of those statements now. This is from Professor Peter Parrish. The dentition is a major part of overall good health. Endodontics as a discipline of dentistry helps to control root canal infection to maintain the dentition in health and function. Focus of infection and focal infection are two different concepts that have been blurred by proponents of the latter. Focal infection concept has been convincingly discredited as having no scientific justification and are based on opinion, creating misunderstanding and fear in the lay community. The theory therefore consists of very old narratives and stories with no real evidence attempting to relate root canal infection with distant disease. Such tales are more accurately considered myth rather than science. Treatments based on focal infection theory lead to tragic consequences for patients. Focal infection theory must be considered a cruel myth. Gentlemen, does anyone want to add anything to Professor Parrish's statement?
You know, totally agree with his statement that, you know, we're focal infection, we can definitely treat whatever that's localized. so focal, local, and I think that what he's pointing to there is right on the dot. I totally agree with his statement, and I think it's a myth that we talk about focal infection spreading to other regions of the body, and even I think Maury, you mentioned that even the cardiologists, I think. The Heart Foundation stated that there's even then, you know, we should be careful when we have a correlation association and we go cause and effect. And that's the problem. Correlation association, very different to cause and effect. And I think even the Heart Foundation studies talk about bacteria from root canal treated teeth that are localized, that we can definitely localize it to a confined space. It's not going to cause any issues to result in more heart disease.
Well, we've had an excellent question from one of our viewers. This documentary makes a number of spurious claims about the links between oral health and systemic health, i.e. the focal infection theory, and comes at a time when the dental profession, is trying to make patients understand the connections between oral and systemic health. Is there any risk that in rebutting the erroneous arguments in this documentary, we might inadvertently confuse patients and undermine our our correct and proper efforts to relate oral and systemic health in other areas? Laurie, what do you think?
Yeah, it's a really important point, Peter. I think dentistry has done a lot of good work in the last 20 years to try to help our medical colleagues and people in health understand that, you know, the teeth are part of the body and that oral health does reflect back. And there are so many examples of it which we've now come to understand, from diabetes through to aspiration, pneumonia, and all sorts of things that can be linked to periodontitis. I think we just need to give a really, really clear message to patients. And I think it all comes down to the focus of infection versus focal infection, because it's widely known now that burden of infection, be that a respiratory infection or a urinary tract infection or a skin infection, all those things add to total changes in the way that the body is behaving its normal function. So it's totally practical and indeed obvious that infections in the mouth, if they occur, will be having a consequence in terms of things like fever, weight loss, changes in glucose metabolism, and so on. So I don't think we want to throw away that really, really important message. We just need to make patients understand that it's the focus of infection, the focal needs local, as Mehdi said, and not the idea that it's causing some really, really distant effect on some organ that's a long, long way away and is not actually physiologically connected to any of the pathways which are occurring from the teeth.
Look, I'd love to bring everyone else in here, but we do have to keep moving because we have a lot to get through. Well, next, the film makes the claim that we're not seeing all of the infections that are there. So, Mehdi, I'd be keen for your thoughts on this clip in a moment.
About 95% of dentists have X-ray equipment in their office, which is only two-dimensional, which means when they take the X-ray from here, they can only see width and height on the tooth. They can't see depth. And you might take a picture of a root canal tooth and it looks fine. But if you do another kind of X-ray, it's called cone beam. It's almost like a CAT scan, where you can get a three-dimensional view of that tooth. We very commonly find that these root canal teeth are abscessed, and there is an abscess sitting around the tooth that isn't visible on the 2D X-ray.
Well, Mehdi, you have a dental background, you have 2D and 3D imaging available. How can you help us make sense of that?
I think cone beam CT technology is great. It's improved our assessment of the tooth. However, the issue with cone beam CT technology is that I think we overuse or abuse it, and also we're not trained a lot of times to be able to read it well. And it's very important that we get the appropriate training, and I'll make the statement that no two CBCTs are alike. So no two cone beam CT images are alike. So increased sensitivity is what it gives us, but lack of specificity. And I think that what we see on a radiograph, and I wanted to just throw up an image, so we see lack of mineral. That's what we're seeing. So the black area around those roots, which over time heals or remineralizes, is the body's response. So by treating the tooth, and these days with obviously technology, you know, rotary endodontics and disinfection, which we've got better at agitating the area, we're able to get complete healing in many of these cases. Okay, and so the reality is that that is enough as a tool for us. We're not going to overexpose patients, but there is a problem also with cone beam CT technology that people don't know about. We do have a index to be able to measure healing, and what we see on a radiograph, for example, widened ligament, ossific classification 1 for normal, healthy, 0. However, we don't have that in cone beam CT, and the cone beam machines are all different, and they give you different results. And sometimes you may even not see a lesion, believe it or not, on a cone beam when there is a lesion, because of the, again, lack of the equipment, understanding of the equipment that we're using. So let's go to that other image that you showed. And incidentally, this was just an image that I'm showing where you can see 2D and you can follow it up and you can actually regenerate teeth that are infected. This is the young patient. This is the, say, the author's tooth that had been, you know, traumatized. Now we can get it to develop over time into a normal, you know, root thickness and strengthen the tooth even after it's immature. But let's go to that other image that you showed, which is a cone beam image. So this is Ollie Pope's paper in 2014, which indicates that these teeth are vital, but what you see is a radiographic appearance on a cone beam of a lesion. So it's not enough just to see a lesion. In fact, I think we spoke to Laurie last night, we just had a phone conversation. I think at their grand rounds, Laurie, you can sort of touch on that. A prosthodontist referred for multiple endos. The multiple endos were done, but it was picked up as segmental dysplasia. A Staffan's bone cyst, for example, that you might pick up on a cone beam. Let's say on even a 2D, may not be something you need to treat. The next image is a very important image. This shows normal, healthy tooth. What do you see? You see widened ligament. Does that mean that that lack of mineral means disease? And the answer is no. So whatever lack of mineral you see, you got to treat with care. And I think the last image I've got is an image of, this is Dr. Brewer's brilliant work of a retreatment. Yes, he's checked it off with a cone beam CT, to show that things healed in that mesial root. But I mean, at the end of the day, we don't always need that. I think we can stick to 2D. We shouldn't forget about 2D technology and start to all do 3D when we don't understand what we're talking about. The last point is that Dr. Minkoff has, in my opinion, no understanding of histology, because he's talking about abscesses. These are not abscesses again. These are just lack of mineral, body's response, normal response, osteoclast coming in, creating room, and then when things heal, they go back to remineralizing and going back to laying down bone.
All right, well, let's have a look at this next clip that talks about how a root canal treated tooth, essentially the infection can't heal.
You can't get rid of an infection unless you have a viable immune system with complete access to all the parts that are infected. And this is uniformly eliminated when a root canal is done.
Now, I guess if we cast our mind back to the radiographs you just showed, Mehdi, there did seem to be some sort of healing. But Laurie, what can you tell us from your perspective on that?
Peter, we've done lots of studies which we've published looking at what happens around the periapical tissues when there's inflammation. And I can tell you there is a very, very florid, normal, healthy immune response that occurs in the periapical tissue. And of course, if there's organisms and their products in that region, your body is going to send neutrophils, macrophages, lymphocytes, all the usual members of that orchestra are going to turn up. And the way that immune system runs is exactly the same as you find in other places where infection is being walled off. And a really good example would be to think about conditions like tuberculosis, because here's an example of where the body has actually walled off a little nidus of infection. And to show you how important that is as a process, at the present time, 1/3 of the entire world's population has an infection of tuberculosis in their lungs. But only a very, very small proportion of those people are actually showing active tuberculotic infection. So that's an indication of how effective the response is in terms of being able to hold off when infection is present. And that's exactly what happens around this periapical lesion. And when it goes into healing, as Mehdi just said, the cells go back into a healing regeneration mode and we form bone and the area disappears as mineral is laid down and deposited. So the idea that there's something different about the periapical tissues is actually completely crazy. As dentists, we all know that when we remove a tooth, the socket bleeds. There's clear evidence of a vascular response which is present. So I think it's quite misleading to somehow describe what happens in the region around a tooth as different, because it's not.
Well, Maury, this next one is for you because the film returns to the subject of root canal treatment and cancer.
97% of our breast cancer patients in an age between 30 and 70, we tested all these patients. They had a root canal or a toxic situation in the teeth.
Sounds pretty concerning. What can you tell us?
It is. I guess one of the things that, again, I found that some of the terminology that has been used in this film is quite difficult to understand. Like toxic situation in the tooth, I'm not sure, that's a broad term. And I'm not a dentist, but I assume this is not a clear terminology. They mention about either they have root canal treatment or a toxic situation in their teeth. But besides that point, I think I come back to that level of evidence. There's no published data anywhere in PubMed or in Medline that you can find any correlation between root canal treatment, tooth infection, and the breast cancer. And conversely, if you look up, I found a study that they looked at, it's a relatively pilot study, but they looked at actually 160 patients. This was 80 patients with the breast cancer and 80 control cases. This is the study that their goal or the aim wasn't in fact to look at the root canal and correlation with the breast cancer, but they were trying to see if there is any oral health issues in the patients with the breast cancer after their treatment, and they could compare that with the age-matched control group. These were the control was the patients that they presented to the ordinary dental clinic with, just for the routine checkup, or they have the, dental issues. Now, I had a table, and the reference is on the website.
Yeah, so the references remain on the they're downloadable. And they'll be on the website as well as other statements. So there's quite a bit of material if anyone wants to go back to the website.
That's the ASC.
ascnsw.org.au.
So the good things about this study was actually, fortunately, they actually detailed the oral examination in that study, including the missing tooth and including any sort of endodontic treatment. So if you look at the table that later on people can have a look, they compared the number of the root canal on average for the 80 patients with the breast cancer, and compare with the control, and the average number of the root canal was 1 in the patient group and it was 1 in the control group, with the p-value of 0.99. Practically, p-value of 1 means there was no significant difference between the two groups. And I guess this is a case control study. It's probably a level 3 evidence, at least indicating that there is no correlation found in this study. And in the absence of any other study to show the correlation, I think we have to absolutely say there's no value apart from a speculation or idea from some potentially clinicians. But I guess there are other studies that they looked at different cancers as well, and that such a correlation has not been found.
Well, Laurie, can we just go back to you for a moment? I think the quote refers to a root canal or a toxic situation. Is there a possibility that various conditions are being conflated here and coming up with a misleading figure?
Well, Peter, I think the fundamental problem here is the difference between cause and effect and simply association. So you might say, 97% of women who had breast cancers wore shoes or underclothes or bras even, or ate chocolate or drank milk. It's absolutely nonsensical to simply say, simply because some of them had one feature, that feature is actually the sole feature that's responsible for the problem that they've got. That's just completely crazy. You need to look at a large range of different sorts of intervention, as well as biological plausibility. There is nothing about a root canal treatment that introduces the sorts of errors in cell proliferation and the loss of control of cell turnover that actually leads to cancer. You need to have promotion initiation. There's actually the elements of cancer causation are really well known, and those are not the things which have anything to do with a root canal at all. So this is one of the most laughable parts of the entire video, despite the fact that the gentleman saying it can seem quite convincing, but in fact is just completely silly.
Look, we've talked a lot about studies this evening. This next clip does contain what sounds like a genuine reference. So let's have a listen and also hear what Dr. Brett Gilbert has to say in response.
Data we've just recently gotten shows now that the #1 cause of heart attack is a root canal treated tooth. Plain and simple, not correlation, not link, cause and effect.
If you take a course through Bale and Doneen, and they're the leaders in cardiovascular event prevention, they will tell you they will not condone having a root canal in your mouth because that bacteria courses through your body, and that bacteria is known to affect cardiovascular disease.
In this segment, Dr. Ewing actually gives a reference. She talks about Bale and Doneen, who are well-known cardiovascular prevention specialists. And they have come out with a statement saying that they have been misrepresented in this documentary. In their latest paper in Postgraduate Medicine, they actually talk about high-risk periodontal pathogens as being responsible for some atherosclerotic inflammation, which will affect your heart. They actually make no mention of endodontic pathogens. Now, in the statement, they also discuss that they are not for or against root canal treatment and that they depend on the oral health specialists, dentists, dental specialists, dental hygienists, to help in partnership to make sure that patients are getting optimal care for their oral health, recommending that patients be aware that their oral health affects their systemic health overall. But it is very clear that what they state is that they have been misrepresented in this movie and that they absolutely do not stand for or against root canal treatment, as Dr. Ewing has implied that they do. And I think it's important because in the one segment in which a reference was given, it was misrepresented, and this misrepresentation of facts is dangerous because patients are influenced by this and may make oral health decisions based on misinformation that is false and quite honestly dangerous to their health.
Well, thanks, Brett. We now have another statement from an expert in the field. This is from Professor Ove Peters. Every now and then, patients may be alarmed by notions that root canal treated teeth may have detrimental effects on distant organs and structures. These thoughts refer to bacteria left over in the root canal system after treatment that somehow escape and damage other sites. This idea was first popularised 100 years ago and is today understood as clearly null and void. It's worth noting that the reported detrimental effects of leftover bacteria or other issues such as bone defects associated with tooth extractions or artificial substances such as implant materials have never been proved in controlled experiments or clinical studies. In summary, the overall health gain that occurs through successful pulpal therapy is very significant. The likelihood that local or other complications do occur during treatment or afterwards is extremely low, leading to the conclusion that endodontic treatment is very safe and effective. This next clip is mysteriously saucy. I'm not quite sure what the filmmakers were getting at, but let's have a look.
So your dentist says you need a root canal. Apart from running for the door, what are your options? Firstly, if the tooth needs to be removed, make sure you see a holistic dentist, one who can remove the infection and periodontal ligament properly. Then, once the tooth is removed and the mouth is healed, you have 3 good options. Your first option is to get a bonded ceramic bridge. Your second option is to get a zirconia implant. Now, 99% of dentists will recommend a titanium implant, but that is just as bad as a root canal. So make sure your implant is zirconia. Then your third option is a good old-fashioned denture. Keep smiling.
Well, Maddie, what have you got to tell us?
I think as dentists, we like to be predictable with what we do in terms of the treatment modalities we have. So the first thing is she's giving options to the patient, but nothing would ever replace the natural tooth with bias, because I'm an endodontist. I have to do that. I have to say that. Nothing will ever replace the natural tooth. So that has to be given as an option, as well as, of course, no treatment if she's giving all the options. And then we move on to titanium being not preferred compared to zirconia. But when I speak to other specialties, especially periodontists, they say that the evidence they have with zirconia is at this point weak or not long term. And that's why they will continue to do titaniums, because from 1952, when Brannemark placed these titanium fixtures in rabbits, and they randomly osseointegrated, they've been used till now. And if this was the case, where we should be not placing titanium implants, then what about all those titanium screws and knee replacement materials? So we'll be taking everything out and replacing them with zirconia. Now, the other thing about zirconia is that we still don't know complications and how to manage complications. So at least with titanium, we know what to use to manage complications in terms of screws and how we can manage that. Lastly, bridge work. Forget dentures. We're not going to even discuss dentures. Everybody here knows if you're going to have dentures, you're going to lose more teeth. There's going to be more periodontal disease. It's very difficult to chew with it or function with it cognitively. And I know people do have dentures, but let's leave that aside. That's not the best option in my opinion. What about bridge work? You know, a bridge would mean, like the author of this Netflix root cause clip, it means that according to the literature, what we're finding, I mean, there's just one example, it's in the reading list, Elias 2015, over 10 years, 20% of teeth under bridge work undergo necrosis. So apart from periodontal disease, not be able to clean around them, we've got a problem. We've got a real problem. That's
and apparently can't do root canal.
Well, the thing is, if you do end up having root canal, you're going to lose the bridge. Or what about the other poor tooth that doesn't need it? So let's leave that topic. Yeah, next.
All right. Well, let's return to the heart of the matter and talk to you, Laurie, in a moment about this next clip.
So, in doing the testing of the bacteria, we found that there are in root canals 53 different bacteria. 28 of them are directly involved with the health of the heart, that they are known from the scientific literature to create certain heart conditions. Some of them specialize in attacking the heart valve. Many of them cause what's called endocarditis, inflammation of the vessels inside the heart.
And we now have studies from the Journal of the American Dental Association that show that when you have one or more root canals in your mouth, statistically speaking, you have a greater chance of heart attack, plain and simple.
Laurie, can you help us out?
So getting to the heart of this matter, a couple of things. First of all, the microbiology of what's inside the root canal is grossly inadequate. In fact, it's been inadequate right back to the time of Weston Price and people before him, because it's based on the simple assumption that it's what you can take out and grow. But in fact, we know using molecular methods that there is actually many, many more sorts of organisms in a root canal. And there's also fungi, not just bacteria. So when you do use modern molecular approaches, you find it's a more diverse situation. What Huggins was referring to was actually, without naming it, was just the everyday streptococci. And it's true that there are some streptococci found in a root canal, although they're not necessarily the dominant organism which you would find there. It's well documented in many, many studies, particularly from the University of North Carolina, from Jim Beck and Steve Offenbacher and others, that it's people with periodontal disease and incredibly strong levels of gingival inflammation who get bacteremias during chewing and during brushing and during clenching and during flossing. Lovely work on that done in Australia by Chris Daly, a periodontist in Newcastle, and others, has shown that you get these bacteremias during normal everyday function. They're actually nothing to do with having a root canal whatsoever. In fact, if you look at bacteremias leading to endocarditis, the majority of those actually come from staphylococci. And Mehdi mentioned earlier that passing a bowel motion is actually one of those things, scratching your skin. We get staphylococcal bacteremias all the time. And some recent research published in March 2008 shows beautifully that these are one of the biggest contributors to endocarditis in patients who are at risk. And those patients are normally socially disadvantaged or have certain genetic backgrounds. We're not talking about something that applies to everyone in the population as an even level of risk. So I think it's grossly overstating it to actually try to link endocarditis, one condition that occurs in many ways from normal bodily function all the way through to serious cardiac pathology such as a myocardial infarct or a heart attack.
Okay, well, this next clip even refers to a smoking gun. It also features some suspenseful music. And following that, Brett Gilbert has a few comments to offer.
By coordinating with dentists around the country, over 5,000 extracted root canal treated teeth were submitted to Dr. Haley for testing. 100% of them were toxic. And just to make sure this wasn't something that just had to do with the tooth or the mouth, they also submitted some teeth that were extracted for orthodontic purposes. In other words, normal teeth, but they needed to let the other teeth grow in. None of these teeth inhibited any of these enzymes. This was finally the smoking gun. This was cause and effect, that the root canal simply cannot be sterilized inside the mouth. It cannot be put into a situation where the infection inside the root canal can ever be resolved.
In this segment, the description of Dr. Boyd Haley doing a study on 5,000 extracted teeth that have had root canals in the past and describing them as toxic is not followed up with any type of reference or bibliography. What they're describing is teeth that were extracted for a reason. Were they periodontally involved? Did they have decay? Had they been fractured? Did the patient have terrible oral hygiene? We have no idea. None of that information is given. All it's saying is that teeth that were extracted because they were diseased show toxicity. Now, they try to contrast that by saying that healthy teeth that were removed because of orthodontic reasons showed no toxicity. Okay? My question is to make this study in any way valid, you would need to extract root canal treated teeth that were healthy and study those as well to give a comparison of how root canal treated teeth do over time. But the point here is that those teeth were unavailable for study because they currently are residing within the patient that grew them. Root canal treated teeth can be maintained for a lifetime and be completely healthy. And so I think it's important when you look at this smoking gun that he describes in this segment, that you understand that there's really no evidence at all with no comparison to healthy teeth. This is completely invalid. It really has no meaning whatsoever, and in no way implies that teeth that have had root canal treatment are in any way a risk to someone's health.
Mehdi, any thoughts?
Well, I totally agree with Brett that you just can't, again, it's the same thing. You can't just, with low-level evidence or no evidence, discuss these things that root canal treatment results in other diseases around the body. So yeah, no, that's fine. I did have just one comment again about endodontic therapy, and I think someone mentioned antibiotic prophylaxis. I would only, following the Heart Foundation, guidelines, would only prescribe pre-op antibiotics or prophylactic if I'm worried about gingival, placing a clamp on the gingiva. So I actually agree with Laurie that, maybe that's the bleeding from other sources, such as the gingival tissue, may result in more bacteremia than actually endodontic therapy. So actually on the guidelines, it doesn't state you need to prescribe pre-op antibiotics or prophylaxis, just if you're doing endodontic therapy and you're not worried about placing the clamp on the gingiva.
Okay, well, let's look at one of our audience questions again. Is it fair to say that any bacteria remaining after successful root canal treatment would not be able to proliferate due to lack of nutrients, i.e. the root canal is sealed?
That's correct. That's right. So we have this thing called entombment, and there is indirect evidence for entombment that you can leave bacteria behind in the root canal. You take samples of it and it's got bacteria, but as long as the root canal system's cleaned well to a high level, below a threshold that causes disease, to the right length, patency established, especially in cases with lesions, then that is correct. The statement that was made is correct. You can leave the bacteria behind, and as long as you seal it, they have no access to nutrients, to gaining access to other bacteria to proliferate, or in synergistic effects, so that they just remain in that situation, in that status quo. Within tubules or lateral canals, it makes absolutely no difference. As soon as we see any signs, patient would know. Patient would definitely know.
Okay. Well, look, obviously we couldn't play every part of the movie without making an hours-long event. Maury, the last clip we have for this evening is for you. So let's have a look.
Perfect example, we had a patient referred to us who had stage 4 throat cancer. The bottom line was he had 2 root canal teeth. The radiographs looked pristine, and 1,000 dentists that would view them would say these are absolutely normal. The pathogens that were in these 2 root canal teeth were in his throat, exactly where the cancer was. I extracted the 2 teeth, we ozonated the jawbone, homeopathics, and ionic silver. In 3 weeks, the stage 4 throat cancer was totally resolved, documented with PET scans, blood tests, and visual. This is the impact of toxic root canal teeth.
Well, I have to say this part of the video is the one that it brings my blood pressure really high.
It sounds amazing to me. Let's just fix everything. But are these sorts of claims hurting anyone?
I mean, it's actually pretty familiar for me in my routine practice, because we see a lot of our patients that unfortunately believe these sort of alternative medicine as a cure. These are unproven promise of cure that desperate patients, they go and pay tens of thousands of dollars and with no good outcome. But coming back to this video clip, I've got a few issues with, firstly, the case report. I would say that it has been shown in this case, the removing of the infected tooth or root canal, and also having all of these treatment, homeopathy, having ionic silver, as well as ozonating the jaw bones. I'm wondering which one of those helped to cure the cancer. Was it the removal of the root canal, or was it those alternative medicine? I have to say, none of those alternative medicine has been proved to be efficacious in treatment of cancer at any scientific base. Now, the other issue is that it was mentioned in the video that the pathogen was found in the root canal, was found in the cancer. Now, firstly, a presence of the pathogen in the cancer, in the tumor, does not mean that this cancer has been induced by that pathogen. It simply could be a superimposed infection. If, in the worst scenario, if the mouth is infected, the cancer can get infected, but it doesn't mean that this is the cause and effect. And the other issue that, it's claimed in this video that within 3 weeks patient was cured. Now, the cure term is a big term to put on any patients. I mean, being in the field of oncology, when you see the complete response in the patients, the cancer can come back within weeks, months, year, or even years after the treatment. So without having at least 10 plus years of the follow-up, you can't say this patient has been cured. I have to say, this is very sort of broad description of curing a patient with the head and neck cancer or throat cancer by removing the root canal and giving these homeopathic treatment. And at the best, this is an unpublished case report without any peer-reviewed, looking at any details of those PET scan, the histopathology, and the rest of the sort of, upfront diagnosis and the follow-up. But this would be not even a level 5 evidence to say that the root canal has got anything to do with the cancer. Now, interestingly, if you look up the literature, there is a very interesting paper which was published in the Journal of Oncology in 2013. And in that paper, which was actually which was the study was done in the Roosevelt Park Comprehensive Cancer Center. If you ask any medical oncologist, they would know what the Roosevelt Park is, because we've got a lot of chemotherapy protocol which was actually developed in Roosevelt Park. It's well-reputed comprehensive cancer centers. So, and they have done really large number of the patients. They looked at these patients in the, I think it was close to 400 patients with the diagnosis of the head and neck cancers, and they compared that with around 220 control cases which they had no history of cancers. Similar to one study that I said in the breast cancer situation, they look at these patients that they walked into the dental clinic with different issues and not cancer. And then they compare, and the aim of the study was to see if there's any correlation between dental caries and head and neck squamous cell carcinoma. And again, when you look at the details, fortunately, in that they've got a table that they showed the number of the root canal, and it's very interesting figures. So because what they showed, there was 71% of the patient with the head and neck squamous cell carcinoma, they had no past history of root canal treatment. And that was in comparison with 60% in the control group that they had no history. So practically there was 29% of the patients with the cancer, they had history of root canal, and there was actually 40% in the control group. So it was almost 10% extra in the patients that had no history of cancer. And this was actually statistically significant. And what it means, if you look at purely in that study, it actually says that having root canal can protect you from having head and neck squamous cell carcinoma. So I'm not saying this is the case. I'm not, but this is at least say that what has been published or publicized as a root canal being a cause for the head and neck cancer, and removing that can cure the head and neck cancer in a way with adding those sort of homeopathic treatment. I think there is no value on that.
Okay. Well, my apologies. It seems as though we do have one other video and then Brett's response.
Root canal treated teeth can be a silent type of infection. I've taken out numerous root canal treated teeth that looked completely fine on the X-ray. And yet, after we took that tooth out and cleaned out that socket, we would find a large area of dead bone or an actual cyst or even actual pus and infection in there.
And then I discovered the father of biological dentistry, Hal Huggins.
I mean, if you've got a ruptured appendix, you're going to fill it with wax and put a gold crown on it? You got the same bacteria there, only the ones in the mouth may be worse. The question is, do all root canal teeth have to be removed? The answer is no, only in those people who are interested in their health.
In this segment, as Dr. Freeman describes the type of scenario that occurs with a diseased tooth, with an abscess, a cyst, purulence, or pus, this, of course, can be associated with a root canal treated tooth that has become diseased. And that can happen for a variety of reasons. The tooth could have developed periodontal disease. It could have decay. It could become fractured and need to be removed. So everything there is appropriate. The problem is she insinuates that all root canal treated teeth are in this condition. And she states something about 3D imaging or CBCT. CBCT can certainly give us an understanding of what the health or disease of a root canal treated tooth may be. But what she doesn't tell you is that most of the time when you evaluate these teeth, they're perfectly healthy. The 3D imaging shows healthy structures, healthy bone around the tooth. That tooth is doing beautifully. It's serving the patient in a beautiful way. And that tooth has had a root canal. Now, when they mention Dr. Hal Huggins, it's very important to recognize that this is a person who has been accused by the Food and Drug Administration as being a deceptive advertiser. In 1996, he had his dental license revoked by the Colorado State Board of Dental Examiners for a variety of different reasons, including gross negligence. During this hearing, the administrative law judge, Nancy Connick, made a statement as to say that they asked Dr. Huggins to provide references, evidence of his theories regarding mercury toxicity, root canal treatment, and other instances when he was unable to provide any type of literature or evidence and became quite disgruntled when she asked him to produce that. He never was able to produce those literature references. This is a person who has been shown to be deceptive, been shown to be capable of negligence, and this is the father of biological dentistry, which is what's being presented here in this documentary. So I would ask you, how far would you follow Hal Huggins as a leader? Because to me, he poses a risk and a danger to all people and public health in general by disseminating and continue to perpetuate false misrepresentations of facts that are dangerous to everyone.
Well, we have one final statement from an expert that we can address now. This is Dr. Colleen Shull from the US, I believe. The College of Diplomats of the American Board of Endodontics mentors endodontists for the ABE board certification examination. Board certified endodontists review hundreds of scientific journal articles to form the scientific basis for the root canal treatment they provide their patients. To date, no valid scientific research has been published to link root canals to cancer, heart disease, or any other chronic illnesses. Well, gentlemen, let's look at the narrator in this. What do we think actually was wrong with him? Laurie, can you offer any thoughts? If it wasn't his root canal tooth?
I would have asked whether he spent much time in Northern California and could have been bitten by a tick, because there is a condition not widely recognised in Australia. We certainly see some patients here. He could have picked up any number of immunosuppressive viruses. Barmer Forest would be a classic one, EBV. There's a whole range of things that would, with proper investigation, actually come out at the end of the day. And I think part of his issue was that he actually wasn't looked at comprehensively. He was given part of a story, but in fact, the real truth of the story is that, yes, you can inhale your plaque and get pneumonia, but that's not your root canal. You can certainly get bacteremia from around some fairly poor periodontal sites, but that's not a root canal. And your oral bacteria can certainly metabolize the booze that you drink and convert the ethanol into acetaldehyde. That's a carcinogen, but that's not from your root canal. So the whole problem with the movie is it takes the elements of some things that we know are true and proven, but completely distorts them. And I think his susceptibility to these half-truths is a problem. And it's, as a profession, something that we do need to address. We need to make sure that patients are given the truth and the best information that we currently know. A very famous doctor called Cotton, who was in the US around the time of 1920, believed that you could remove teeth to treat psychiatric illness. And that led to what was called in the literature an orgy of therapeutic edentulation, where many patients were rendered completely edentulous. Later, Cotton was inspired to start removing gallbladders and then a whole range of other organs. What became obvious after the time of his death was that the results he had claimed for benefits were falsified, and that over 1/3 of the patients who had operated on had actually died as a direct result of his surgery. This man was a mass murderer, much, much worse than some of the other people at the time that we tend to think about. So we need to realize that there are some wrong messages that patients can be given, and that can lead to a lot of very, very poor outcomes, as Brett and Medi and everyone else on the panel has talked about tonight.
Well, we're talking about what we should be telling our patients. Maury, what would you tell a patient who felt that their cancer, being managed by you and your team, happened to be caused by a root canal tooth?
I mean, probably in the end of this session is not to have a bit of laugh as well, but I can give you an example of there was some proper data if you Google it, you can actually find it. But they actually showed that there is some correlation between ice cream consumption and shark attack. I'm not sure if you have seen that, but you can propose that this could be because the people who eat the ice cream, it might make them more tasty for the sharks. But alternatively, you can think that this is a seasonal effect, and it could be the fact that, the hot season, there would be more selling and consumption of the ice cream, and there would be potentially more people swimming in the ocean.
Well, that's great, because I could give up swimming in the ocean, but I'm not going to give up ice cream.
So I guess that's come back to that correlation and causation. So if there is coincidental things, it doesn't mean that this causing that. And the fact that the root canal is such a common thing in the population, it doesn't mean that that is the cause of the cancer, unless there is good studies show that there is some sort of cause and effect. So I think, and in fact, I have to say, in our world, this has become more wider and more common in a lot of other areas. I mean, this is root canal, but we see a lot of these unproven alternative medicine that the patients, because of having all these information and not being able to distinguish which one it's a valid scientifically based sort of factors compare with something that has got no scientific value. So I think this is the things that we have to probably try to educate our public a bit more about, being to understand, and try to search in the proper channels rather than whatever they take and they believe on the media.
Well, Medi, how are you handling it with your patients?
I think this is the reason why I asked, through the ASC, Australian Society of Endodontology, and through the committee of the New South Wales especially, and throughout ASC, by the way, Queenslanders are watching. I think Victorians just finished their lecture. They had a general meeting, but some of them are watching, I noticed. So the reality, I think, is that we give this to patients that are not on the fence. This material for dentists as well, because dentists always ask, what do we do when a patient asks about, I've got cancer now, could it be all these endodontic therapies that I had? And I think that this is why tonight's event would really help, because for me to spend an hour and a half with a patient to try to sort of, they're not on the fence and they're willing to listen, it'll take me ages to explain what we discussed tonight. I think it's a really good, useful tool that we'll hopefully be able to have on YouTube or have it on the site, the ASC New South Wales site, so that then people can revert to, so they know how to respond to patients. But at the end of the day, I always tell patients, look after your systemic health. Look after your body. We understand that there are some, I suppose, diabetic patients can be more prone to, for example, periodontal disease. This is uncontrolled diabetic patients. But controlled diabetic patients are same as a healthy patient. So I explain these things to patients, and at the end of the day, I think we leave the decision in the end to the patient, because patient has the right to decide. But I thought part of tonight's, apart from dentists watching, because 75% of all endodontic therapy is done by them. We only see the 25%, and most often the dentist has already sold the case. They know the cost, they know most of the risks, but we tell them about risk, but we never discuss risks such as cancer or heart disease during the discussions. We never even bring it up because it's not established risk. We always go by best available evidence, and I think this is why, unfortunately, we understand it. But how does the general public understand it? Because maybe they are not familiar with researching best available evidence. Unfortunately, Dr. Google seems to win. And this is why we're putting us on YouTube. This is the first time it's been done in the world where we've got experts as well as help from Brett Gilbert from the States, and everybody's involved.
And our audience. So
it's really root canal awareness, or endodontic therapy works. And let's all quote Tazal 2013. It actually reduces risk of colorectal cancer.
Well, we've had a good question asking, this person is saying, it is said that root canal treatment lasts an average of 10 years despite doing a great job. Why does it fail, provided the reason is not fracture? Is it possibly due to coronal leakage? Mehdi?
Yes, it's multifactorial. So the reasons for failure are multifactorial. We should understand there's not one reason for it, but the most common reason is actually not the failure as a result of bacterial. It is fracture, or it's the bite, and it's the changes in the bite because the bites keep changing, and patients are grinding more these days. We're seeing a lot more teeth being saved, but we're also seeing a lot more patients grind. We're seeing a link between grinding and maybe stress and things like that. So at the end of the day, look, I think if we're going back to coronal leakage, I think everything to a certain degree leaks, but I think the body's very good at coping. We should remember that. And I think we should, again, preserve the natural dentition, because there's one last quote I've got here, Krishnamurthy, 2018. It's a Japanese dental sciences journal. And they talk about chewing is essential. Keeping the natural tooth is essential because it gives you cognitive function. So you're able to feel, so again, going back to implants as well, nothing against implants, but I think that should be a last resort, and they're a really good replacement option. But
so it's saying proprioception is really important.
Proprioception is very important. And Peterson, 2012, mentions that 46% of implants after 6 to 10 years need maintenance issues. So I think endodontic therapy is a low maintenance treatment, because if it doesn't crack the tooth, often it outlasts the patient.
Laurie, can we talk to your tech head personality for a moment? With the recent advancements in 3D imaging, and this will relate a bit to what Mehdi's already talked about, many dentists prefer to take the 3D scans first rather than taking intraoral radiographs. Are the intraoral radiographs slowly losing their place to 3D scans in dentistry?
Oh, there's a couple of ways that you could tackle a question like that. We need to have good available diagnostic tools. And in our lab, we've done some interesting work looking at different ways that you can image teeth, and even different ways you can try to assess the vitality of a pulp. And strange as it may seem, some of those really sophisticated methods don't work as well as a cold sensibility test, which is something that every dentist can do and learns how to do at dental school. It's really, what bit of information are you looking for? And if you know how to read a periapical radiograph appropriately, and you know the difference between a periapical lesion and a cemental dysplasia, which was mentioned earlier, then you can be quite confident when you combine that information with your pulp sensibility test in reaching a good assessment of what's happening around a tooth. We shouldn't just be automatically jumping to the latest, greatest sort of evidence that we've got around very, very sophisticated radiography, because there is ionizing radiation involved. We've done some work on non-ionizing radiation that can be used to image teeth. Coherence tomography is a very promising tool that might replace a fairly large chunk of conventional intraoral imaging that we're doing at the moment. However, it's not a panacea for everything, and I think we will always need radiographs, so we need to be able to read those well, and it's a really fundamental skill that we all need to make sure that we continually hone in our practicing lives.
I might just add to that as well, Laurie. There's something called, with chromium CT technology, beam hardening, so you can get a lot of scatter. So I think we should never not take bite wings. I know there's some 3D dentists and they've got the cone beam, they do 3D before they even consider any 2D, or they may never take a 2D. But with bite wings, you can see restorative margins, you can see caries better, and even with periapical radiographs, you can at least see the disease progression. Again, as Laurie correctly pointed out, there's this thing called relative dose, and I know that we start to do more cone beam, more cone beam, more cone beam, and even endodontists we're seeing more, but I feel embarrassed if I had to ask for a second cone beam because I got in the tooth and I didn't find the canal. I'd rather get into an upper 6, look, then, if necessary, take a cone beam without removing too much tooth structure. So I think we've got to be reasonable with what's there in terms of technology. And we shouldn't forget that if you're sitting there and you've done treatment through a cone beam and you've misdiagnosed or whatever, and there was appeared to be a lesion, the expert on the panel who are going to question you, going, where's your periapical radiograph and shift film, and where's your bite wing? So we shouldn't forget the basics.
That's good advice. Mehdi, one other claim in the film is about what they call cavitations following removal of a tooth, when it's not followed by the thorough removal of the periodontal ligament. Can you enlighten us at all on that topic?
Yeah, I don't think there's any real evidence for it. I read a few papers that I think you might have sent me. The evidence for it is obviously not there because following removal of the tooth, the body's able to dissolve away anything that's left behind. You don't need to, I know some people would, cavitate or induce bleeding and things like that, but I think that the body's response itself, if it's a healthy body, should be as per we used to remove teeth back in the old days.
Laurie, do you have anything to add?
I don't know, but I
think
think Rolly might be able to add to that.
Yeah, I can tell you I've grown periodontal ligament cells from many extracted teeth that are non-vital, and I can tell you they grow very, very well. So there is definitely nothing wrong with the periodontal ligament on a root fill tooth. When you take it and you remove the cells from it, they grow on plates in the lab extremely well. So the idea that there's something actually wrong with the periodontal ligament is actually crazy. That's not what we see, because we can recover all sorts of cells of all different types of phenotype from the periodontal ligament of extracted teeth. And it's been a routine laboratory procedure for the last 30 years, at least of my experience. So no, I don't think that there's something. There is, of course, a procedural risk if you start poking around, and I saw a number of cases of this when I was on the dental board in Queensland, where there was damage to the inferior dental nerve from dentists who were trying to scoop out around the apical regions of lower molars and actually end up damaging the inferior dental nerve. So I think there's some procedural risk that if a patient was told that this procedure may give you lifelong permanent paresthesia, then the patient would probably have something to say about whether they would actually want that done or not. So I think a full disclosure about the risks of this additional procedure, which actually doesn't seem to create much benefit, I think is an important discussion to have. There are a number of very, very small case series looking at cavitations in bone, mostly from Jerry Picot, the oral pathologist who first described it, but he never showed that it was a routine finding. And so it's a huge jump of faith to suddenly say there are these lesions that occur on every root fill tooth and you can't see them, they can't be imaged, because it's just simply not the case. When you look at block dissections, histologically, you don't find these sorts of areas of pathology. So I think we need to have a realism check and once again, go back to what the evidence actually says.
Well, Maury, this will have to be our last question because we're running out of time. What cause and effect could be a remote possibility for root canal treatment causing cancer if it were in any way possible? Is it possible that while the infection was developing in the tooth, or in the case of chronic abscess, that something may now have spread to another organ prior to the root canal treatment?
I have to say the only things that if we assume that there is a cause and effect, which so far there has been no evidence, the only things that I can think of is if the root canal, probably infected root canal, if somehow can impact on the microbiome of the oral flora. And again, with that, I think probably Larry can probably put a bit more light on this, but we know that in the oncology now the gut flora is important as part of the interaction between the gut flora and immune system, which appears to be important in in our sort of immune system responding to the cancer. But all the studies that I have looked at, there's nothing really closely to say that the oral flora has got a major player in cancer. So honestly, I can't think of anything that directly can have that sort of cause and effect. And in the end of that, I might just actually add that the best sort of way to identify risk factors for cancers has been epidemiological studies, and that's where they can actually find if there is anything beyond that, just the coincidental factors. And I want to just add that Eric Jacobs is the senior scientific director of the epidemiology research at the American Cancer Society, and this is a statement that it was published in an article in the Guardian in 4th of February 2019, which was published by Anna Almendarala. So in there, it just says that there aren't any studies that show people who get root canals have a higher risk of cancer. I think this is pretty reassuring statement from someone really higher up in the epidemiological research in the American Cancer Society. I think this is, for me, really reinforced that there is no true evidence for this correlation.
Well, Laurie, your name was mentioned in that. Do you have anything to add?
There is certainly some recent evidence that looks at changes in the oral microbiome in individuals who have cancer, particularly oral cancer. But actually, you need to work out which is cause and which is effect, which is chicken and which is egg. We know that bacteria like adhering to certain types of targets in the mouth. We know when someone has, for example, oral cancer, the nature of the keratins that they express within the cell and the cell surface is different. And this is one of the things that seems to actually drive changes in the oral microbiome. So I mentioned earlier, there are also some organisms in the mouth that can produce a range of carcinogens, and acetaldehyde is one that's been fairly widely discussed in the literature. So you need to work out where there's a chicken and egg problem happening here. It's certainly not unexpected to see that poor oral health and indeed poor oral hygiene has been shown in several studies, large-scale studies, to be an epidemiological risk factor for oral cancer. And that's probably because of the metabolism of recreational alcohol and also a strong comorbidity related to smoking. In some recent work, which we haven't published yet, we've looked at the link between poor oral hygiene in a patient and their carriage rate of oncogenic forms of human papillomavirus. And there seems to be a story there, which we're still unpacking because we're doing some quite long-term studies on that in area of research. However, the take-home story is whether this is cause or whether this is effect. And if we don't know that, then we shouldn't be starting to attribute blame where blame is actually not due.
Well, gentlemen, we're out of time. So thank you, everyone here, and Brett, who I believe is watching very early morning in the US. Thank you for giving up your time to help us to closely examine this film, and so we can, I guess, engage in more meaningful conversations with our patients and hopefully present a more balanced truth. Thanks for being with us.
Thank you.
And thank you for watching. Australian viewers, as Mehdi said, can claim their CPD certificate by visiting the Australian Society of Endodontology New South Wales branch website and clicking the feedback link. You'll also find several of the references our panellists have cited ready for immediate download. If you need any extra assistance on matters we've discussed this evening, you can contact the ASE New South Wales. Good night.